All right. Good evening, everyone, and a very warm welcome to week two of Signia Healthcare's In Pursuit of Patient Safety. As we informed last year, we are trying to bring you WHO's documents and technical reports simplified to all of us so we can do justice during medication administration. So that's where we are starting, and thank you for being with us. May I request everyone to put off your video and also your audio because this is get recorded, and later we will be uploading this on the YouTube. So please put your video and audio off. Thank you very much for that, and once again, a very warm welcome, and let's start. So this is our Signia Healthcare's commitment that we will continue the journey of encouraging people to promote patient safety. And I'm very sure this is not going to be a destination for any healthcare worker or any healthcare facility or services. Anyone can claim that we have 100% patient safety. Why? It's because we are humans and humans can err. So there's a document called To Err is, and that came out in 1999, if I'm not mistaken. But there are many ways we can ensure that we are preventing ourselves and protecting our patients. So, in series of 5 weeks of deliberation, this is week two, and today we are going to discuss about medication safety in high risk situations. High risk situations, medication safety, there are many documents around this, but today we are going to deep dive into the technical report of World Health Organization only. We are not going to talk about the document or anything else. So from this document only I'm going to discuss today. So to set the context, let me just play this video for you to know that how other countries they are actually discussing about patient safety and harm that is coming to patients through medication administration.
My name is Jim Casey, and I want to tell you a story about a time that I helped make things better, because I truly believe that better matters. A man laid in a hospital following removal of his appendix. In the next bed, a man was paralyzed with a breathing tube following heart surgery. A nurse mixed up medications and gave the appendix patient a paralytic that was meant for the heart surgery patient. Without a breathing tube, the man slowly suffocated. Alarms were going off for nearly 9 minutes before anyone responded. It was too late to save his life. By coming forward and pursuing their claim, the man's family was able to help make things safer for all of us, as the hospital changed how paralytics were labeled and stored. Ordinary people with courage can utilize the law to come through their deepest, darkest struggles and help make things better for the rest of us in the process. Please understand that past results are no guarantee of an outcome in your case. But if you need to learn what happened, why it happened, and hold the responsible accountable so it doesn't happen to someone else, contact Casey Law. Together, we will make it better.
So friends, if in India, if I start looking for any such errors which became public, it is very difficult to find one in the in the entire internet. I'm very sure that recently many of us must have heard about Radonda Want trial, where this nurse who had administered, vercuronium instead of midazolam to a 75-year-old lady who was supposed to be discharged, and she was in the PET scan before discharge. And because she said, I'm claustrophobic, I'm afraid to go inside the PET scan. So doctor asked to administer midazolam to reduce her anxiety. And This nurse, she went to the medication cabinet, and there it is all electronic, right? So she must have typed, the midazolam, the trade name is Versed, Verscd, and the other one is Vercronium. So probably when she checked for Versed, probably the Velcronia must have come in. So then what happened there was that there is a warning that this is a paralytic agent. You want this. So probably she was distracted and she override the system. So I would like you to pay little attention to the story, not because that we have electronic systems dispensing the medicine. I have myself heard of stories in India, though it has not come public, where nurses have administered paralytic agent by mistake. Now, nobody is intentionally trying to harm a patient. We know that. It is a human error, we know that. But what happened in this case, I would like you to just read this two comments I got from below this video when I was looking at. The last time I was in the hospital, every time I was given an IV medication, the label was read aloud by the nurse and checked by a second nurse. That protocol was very reassuring. So when I had been a nurse and I had been a critical care nurse, and I know that what all medications we used to manage when you are a critical care nurse. And for one patient, we will be managing, 13, 14 medications. So the chances of making an error is very high in those high risk situations. So it is very, very important for us to be very focused on what we are doing so that we don't make a mistake by mistake. So when I read this, reading aloud, I had this, habit of, reading my orders loud, even if, it is not a high alert medication. I'll be reading it loud to say, oh, dopamine 5 microgram per kg per minute is what I'm supposed to be, right? So those days when I was working in the critical care, we did not have a very clear high alert medicines list or anything like that. But we had some safe practices. And when we are giving oral medications to a conscious patient, I'll take the medication chart, compare all the details of the name and UHID, etc., with the patient's ID band. I will ask the patient, can you state your name, please? And then I'll tell, okay, this is your medication time now, and you are going to get this medicine, this medicine, this medicine, this medicine. Patient is also listening. So I've read that. I open the medication drawer, take out each medicine, and every time I take out, I'm again telling, oh, you have got metoprolol 25 milligram to be taken now, and you have an aspirin to be taken, you have a Lasix to be taken. So I'm continuously reading loud and talking to the patient, and I have, I can tell you it's a very, very safe practice. All it needs is that whenever you are giving medication, just be there, because the chances of us making a mistake by mistake is pretty high. So you can imagine the second comment which is here. As a nurse for 32 years, I can only sympathize with her. I mean, I can also sympathize with the nurse, but she is accountable for her actions. Nobody can say that she is not accountable. So what happened in that organization? So she is also telling, but at the same time, Vanderbilt, this is one of the most prestigious healthcare systems in US. They should be held accountable. So what happens during the trial? It became very evident that these nurses were overriding the system because they were not getting the medications that they wanted. So what happened? An abnormal behavior became normal because they were doing it every time. So we also need to be aware that are we normalizing unsafe practices by not addressing it at the right time? So that's the question that we need to ask ourselves. So that's setting the context. What are we going to discuss today? So I have taken all the content from this technical book, the yellow one here, Medication Safety in High Risk Situations. So we are going to discuss the key steps, as the document says, in ensuring medication safety. We will also discuss about the three contributing factors to errors around high risk medication. Medications frequently considered as high risk or high alert, I mean, they are interchangeably used. Other medications occasionally considered as high risk, most frequently considered, there is one list, and then there is other medication. Then what are the strategies one can to reduce HAMs, high alert medications, or HARs, high alert, high alert medication, both high alert and one is HRM, high risk medications. Okay. Actions to reduce medication related harm due to medication factors. Strategies to reduce medication errors related to provider and patient factors, and then strategies to reduce medication errors related to work environment factors. So, we have pretty much a lot to discuss, but we'll try to keep it time bound. We have given ourselves time till 9 p.m. I'll try to wrap up early. And this abbreviation is available in that document. It's very easily available on the net. In case you are not able to find, you would like to have this document, just send me a WhatsApp message. I will share the document with you. So now most of the full forms I was aware, but something new that came to me was this DOAC, direct acting oral anticoagulant. So this was something that I was not aware earlier. And then there is NOAC, newer oral anticoagulant. Then there is STOP, screening tool for older people's prescription. So rest of the things are all that we are all aware of it. So I just thought I'll put it up there for you. I'm not going to go through each of the full forms here. Now the technical report starts with this one story. Let me try to summarize it into a very short story. So this is 65-year-old lady. She is a non, she's already taking cardiac medicines, and then she had come with complaints. The first story it goes is that she has come with complaints of abdominal pain and dark stools. So 3 weeks ago, she had come and she was complaining of, muscle pain, for which she was started on non-steroid anti-inflammatory drug diclofenac, and in India very famously probably it is known as Voveran in India also. So she was taking all the other medications. So she was given that medication, and in between she had come back with symptoms of blood loss because she was feeling tired and she was having dark stools. So the doctor, he stopped the diclofenac and he started on omeprazole. So it's a proton pump inhibitor. I'm sure that you're all aware. And he told this 75-year-old lady that you stop this and we will start this. So pharmacy gave all the medications, and unfortunately the documentation was not done to stop the diclofenac. So diclofenac was still in the prescription. So all the medications were given, including omeprazole. So the son saw and he said, okay, I only have to start omeprazole. So started omeprazole, continue with the diclofenac. That's when she landed up again with abdominal pain and dark stools. So she was actually bleeding. So how did this happen? NSAID, when you give to patients, especially elderly patients, it becomes a high risk. So then the doctor realized what happened because 75-year-old was not paying much attention what was being advised to her. So this is one context that how medication errors can happen even in an outpatient setting. Forget about the inpatient setting. So now this document talks about the key steps in ensuring patient safety. The medication safety. So the first one is the prescribing. That's where everything starts. So the responsibility of the prescriber, the doctor, is to understand the patient very well and weigh the benefits and risk for the patient and prescribe the right medicine in the right dose through the right route. So we know all the rights. So prescription also follows the same rights. And the doctor is expected to also review the previous medication. So every time when a medication is being prescribed or is given, there is a check that is happening. There is a reconciliation of drug that is happening. So doctor has to look at what all medicines the patient is already taking. So many times it can happen that maybe you yourself might have experience when you call a doctor and say, I have got such and such problem. Sometimes they don't ask us what all medicines are you taking at the moment. So it is very important for the clinicians who are prescribing to keep that in mind, but most importantly, educate the doctor. So when I was in the hospital, when I was in Fortis, we always used to advise patients that when you come for your OPD, not only bring the prescription, just bring all the medicines that you are taking. So it's easier for the doctor to see what all medicines you are taking, and in case there is a mismatch, they can catch hold. Maybe this is something that you would like to explain to your patients. Then the role of the pharmacy, the dispensing, preparation, and then administration. Administration, by and large, the maximum percentage of administration is with nurses, especially in the hospital setting. So I'm going to discuss more about the hospital setting than from the community setting. So there, are we engaging? Are we communicating with the patients? How many times I would like to ask all of us that when we give medicine, how many times persistently that we identify the patient correctly? I've had nurses who tell me, ma'am, I know this patient, I'm looking after this patient for the last 5 days, why should I again identify him? The answer is, to err is human. You can be distracted. You just saw in the first video, patient post appendectomy, the other patient post CABG on ventilator. By mistake, the verapamil is given to the patient who is had appendectomy. That's a real case. The family has started that foundation. So this can happen with any one of us. I'm very sure the nurse didn't want to give acronym to that appendectomy patient. So there is so much that we can do by just following the protocols that are laid down for us. And then every time doing a medication reconciliation. That means when a patient comes, gets admitted to the hospital, take a stock of all the medicine the patient is taking at home, and then what is being prescribed in the hospital, because some medicines may be stopped when a patient comes to the hospital, which may need to be restarted after certain few days or an event or something. Sometimes it happens, patient may be on some anticoagulant which is stopped for a surgery, minor surgery. You stopped it because the patient might be taking that warfarin because they have some clotting problem, so it was stopped for the surgery, and then doctor is expected to restart the medication after some cooling time. But sometimes if it is not started, patient will get admitted with an embolic episode. There is a possibility. Now, how can nurses help? Nurses can help by just being alert and looking out for the safety of the patient. And I believe that, nurse is the last defense for the patient. If many things can go wrong, it's like the Swiss cheese model, but the final warrior who is standing in front of the patient is the nurse. If the nurse is aware of the medications, if the nurse is aware of the patient's clinical condition, she's knowledgeable, she's confident, she's courageous. She can stop that error from reaching the patient. And this I am speaking from my own experience of being a nurse for so long. And I have seen nurses who have the courage to stand up and speak up for the patient. I have seen nurses who don't like to say, I gave it because the doctor ordered. So we don't want to be called at the handmaiden of the doctor. If you don't want to be called, we become smart, critical thinking, we are aware of it. So let's look at the relationship between medication errors and adverse drug events. So this picture is also from the same document. So you can look here on the right hand side. There are these outcomes. When you give medication, there can be small medication errors which does not result in injury. Errors, mistakes, we know that. Should we report those mistakes? There are small mistakes which does not harm the patient. Should we report it? Report it. Can I have some answers in the chat box very quickly? Should we report those small errors which did not have any injury to the patients? So I am getting some answers. Yes, yes. It is very important that we report because that can be considered as a near miss. Did not reach the patient, but it did not harm. So it is like the tip of the iceberg, telling that this could become serious. So let's take care of it today. So every single error needs to be reported. Then there is potential adverse drug events. Now, adverse drug events are something that we cannot control. We cannot control that, and this can happen with any patient. So, potential adverse drug events usually they don't injure anyone, so that's okay. Then on the left hand side, we have adverse drug events that anyway it happens to patients. Adverse drug reactions which can lead to injury, and there are some preventable adverse drug events. Now, which are the preventable adverse drug events? When we don't check the allergy of the patient, very easy to understand. We did not ask the allergic history of the patient. So we gave the medicine to the patient, and patient had the adverse drug reaction. Now that is very important. It was preventable. We'll be talking about ADRs because this document also talks about two types of ADRs, which I'll be explaining in a moment. So then there are adverse drug reaction. Everything has gone well, and you have given the medicine, but patient had adverse drug reaction, and this is not preventable because this is inherent risk of the drug itself. So preventable drug events, they are medication errors. Potential adverse drug events, they are also can happen because it has led to no injury, but it could have been prevented. Then there are smaller errors, and then there are also major errors like the stories that we just heard. And believe me, I don't know, in my 40 years of being a nurse, how many times I have heard of this mistake of paralytic agent. Many times. And I don't think that in many of the cases, the patients were lucky to be saved. So I can't emphasize that how much we need to be careful when we are managing medications. So high risk situations are important because we need to understand which are these high risk situations, because they are often associated with significant harm due to unsafe medication practices or medication errors. While I'm talking to you, you can just put in the chat box what are some of the high risk situations that you think where errors can happen. You know that in this condition errors are bound to happen, so the people, the doctors, the nurses, everyone needs to be double triple careful. So while you're putting in the chat box, continue with the discussion. There are three contributing factors to it. One is the medication itself, the high risk medication itself, and there are provider and patient factors. We will be discussing each one of them separately. Then there is system factors. System factors is the work environment, the environment in which the healthcare provider is working. So somebody told that it is in emergent situations, that's prescription, they're all they are not high risk situation. Prescription error is from the doctor, they are all medication errors. The situations could be emergency, in the operation theater, when there is a code blue that is happening, when things are not happening smoothly, even in an ICU, when multiple episodes come, it can become a high risk situation. May I ask everyone to mute yourself, please? So let's talk about the adverse drug reaction first, and it's very nice because I've heard about this, two types of ADRs from this document. I've not heard this kind of interpretation earlier, so I'm going to share that with you. So studies have shown that there is a burden of ADR itself. So in one study, it was estimated that 6.5% of hospital admissions had adverse drug reactions. So I know that in our hospitals, we do capture medication errors, but I have not come across that we are actually capturing ADRs, adverse drug reactions. So what are the kind of ADRs that you can have? There are two category. That is category A, type A, and type B. So type A is augmented. Augmented means you are expected to have those ADRs in some patients. So For example, side effects of medications that we learn, sometimes that adverse drug reactions, it's an exaggerated response of a patient to a particular drug. That is very easy to understand. So you stop the medicine, the patient had ADR, and you stop the medication. Type B is called the bizarre one. Bizarre one is the idiosyncratic response. That means you don't know why this happened in this patient, but it happened. So it can happen, ADRs can happen. So let me tell you a major ADR that I have seen in my life when I was working in Doha. It was one of the Indians, I heard that this Indian was admitted to the Burns hospital. And I have never seen such a patient before. I have never seen one after also. So I was told that this patient was allergic to penicillin, and he was in Doha. So obviously, when he was prescribed the antibiotic, the doctor did not ask whether he's allergic to any antibiotic. Neither the patient told that he's allergic. So he was given this, penicillin based antibiotic, and he had that. And I think just after the one dose, he had severe reaction and he had to be admitted to the doctor. And post that, unfortunately, this patient lost all his skin. And actually, I went to the Burns hospital to see that, how severe this can be. And you won't believe it. He was like bandaged, his entire body was bandaged. He could talk, and he was lucky that he was saved from that. So can you imagine that, this was totally preventable, but it had a very bizarre outcome, though it was not just augmented. I mean, some patients can have anaphylaxis. So this is very important to look at the allergy of the patient, and it is a good practice that every time when you give medication, don't just depend on whether it is written in the file or not. I have had instances where doctors tell it was not written there whether patient is allergic. I think it is always worthwhile to ask every time when we are giving medication to the patient that, are you allergic to any kind of medication? Only today, it medications or sometimes, food, it can lead to food and drug interaction. So many types of allergies can happen in our patient. So it is always safer. So before you give it, please remember the call to action words: know, check, and ask. Know your patient, know your medication, check whether you have the right medication, the right patient, the right route, and everything. And also ask the patient whether he has any allergy. So you can interpret that every moment in the medication process. You can interpret, know, check, and ask whether it is for a doctor or a nurse or a pharmacist. It it holds, truth for each one of us here. So now, this is high risk medication. This is something called, very easily we can remember. It is acronym is AIR-PINCH. AIR-PINCH. A starts for anti-infective. So these are very easy to remember. Amphotericin aminoglycosides, and the P for potassium and other electrolytes like the potassium, magnesium, calcium, hypertonic sodium chloride. So when you remember P and other electrolytes. I for insulin, all kinds of insulin. N for narcotics and other sedatives. So all kinds of, opioids and, benzodiazepines, propofol, thiopental, all of them come under this. Then there is chemotherapeutic agents: vincristine, methotrexate, etoposide, and azithromycin. I mean, these are the medications which is listed. And chemo is something that, I am not used to giving. I never worked in onco unit, but all the other medications I have used sometime or the other. And H for heparin and other anticoagulants like the warfarin and your fragmin and other kind of, antiplatelet medications that you give, anticoagulants. Then there is a whole list of others. Now this is very important. This document talks about A-pinch. A-pinch can be, adopted global by everyone. Then the other is based on the country, the city, the hospital, the which unit that you are working. So there can be medicines which are over and above this, which are high alert. So let's say cardiovascular drugs can be high risk for elderly patients. If even elastics can become a high risk for some patients. So you will have your organization's list. So I will just advise that please let's go ahead and spread this APINCH as widely as possible. Let everyone learn about APINCH. The other list will definitely come. And this is from state of New South Wales. I think this is in Australia, if I am not mistaken, or it is in England. England, yeah. So now the country has adopted this pinch. Now this you will come later. Why it is critical to have standardization when it comes to all these kind of processes. So let's look at the medication factors. So please don't worry about these are snippets from that same technical report. You can always read into it. Now I just brought them here just to highlight some of the points which are there. That is your means anti-infective agent. So first of all, aminoglycosides, amikacin, gentamicin, streptomycin, tobramycin, and vancomycin. So if you remember these four, and very easy to remember, renal and liver. I mean, if you look at renal and liver, many of the things, if patient has got renal impairment, liver impairment, many of the medications can become, high risk for that particular candidate because most of the medicines are excreted, metabolized in the liver, excreted by the kidney. So it's very important. And I'm very sure that, aminoglycos is something that I learned maybe 40 years ago that this is nephrotoxic. So we need to always check the renal functions. Streptomycin also we have used, tobramycin also we have used. Now, to know these things and every time you remember, just in case the doctor overlooks this, a smart nurse should be able to tell, excuse me, sir, the renal function is looking like this, so you have given the full dose. So maybe you would like to remind the doctor, and the doctor can order a safer uh, you know um, dose for that particular patient. So amphotericin B, so all these things they have very quickly mentioned what you need to do. So this class is not about teaching about the medication itself, but it is remembering that I have to know more about the medication. And we have to know the knowledge of the medication for any medication that we administer. Last time also we said, if you don't know, please ask. No, not about the medication. This is very, very important. Now, vancomycin, rapid intravenous infusion of vancomycin increases the risk of anaphylactic-like reaction. So now it is important, you know, the speed at which you give medication. It is not intended to be given fast, and you gave fast. Patient will have unintended reaction. So that's something that was avoidable. So that is the preventable ADRs, that we create because we were not aware of the speed at which the drug needs to be given. Was it supposed to be diluted? Can I give it? So I will again repeat, there's only one medicine that is told to be given as bolus, that is adenosine. If you remember that, rest all medicines are not supposed to be given as bolus. Adenosine, when you give bolus, you follow it with the saline, all those things are there. But rest all medication, you can give it slowly if you are giving an IV push. And some medications have to be given diluted, and this is very, very important. Now, amphotericin B, many of you must be using this antifungal. Now, lipid-based forms of medication, they have less toxicity. But if conventional medications, if they are not, diluted properly, then it can lead to cardiotoxicity and cardiorespiratory arrest. Now, these things are very important to be known. So, my question to all of you, do you have a small reference that you can ask the nurses only to create all these A-pinch medications? What are the nursing responsibilities, how we should be dilute? Maybe you can create a one pager for your nurses. Make sure that all your nurses, they are aware of it. You can check them, you can check their knowledge by giving a test only from that content. It is not very important you understand all the pharmacopoeia of that medicine. At least know what is the action, what is the side effect, what am I supposed to observe in this patient, what are the things that I should monitor. This basic information, if each one nurse is able to have, we can create far more medication safety for our patients. The next one is P for potassium and all the other electrolytes. Now many hospitals have removed potassium electrolyte, potassium and other concentrated electrolytes from non-critical areas. And I know that now all the hospitals who are going for accreditation, you have a policy around high alert or high risk medication, how they should be stored, how they should be labeled, Tolman labeling. So we are all aware of this. Now the question is that, are all nurses aware of this? One of the one of the event that I have heard is that the patient was asked to be given, I think, some bronchodilator, and the nurse gave epinephrine. It's by mistake. She didn't want to give epinephrine, but then what is the reason? Because epinephrine was sitting where this bronchodilator was supposed to sit. Now, can we blame the person who actually put the ampule there? It is part of a system error, we understand. But where is the personal accountability? I'm sure that all of us nurses have, learned about the three self checks. One is the order, second one, when I remove from the cupboard or from the drawer, I look at this is the medicine that I want. Before I open and load it, I check once again. And before I give to the patient, I check it again. This three self check, if we do, and I can tell you, my friends, that in my whole career, I cannot remember that how many times I have not done this three self check. Twice. And both times there were medication error that happened, which were not very critical to the patient, but they were errors. Number one, I was supposed to give Lasix 80 milligram and I gave only 40 milligram to the patient. Another time it was digoxin, which I was supposed to give 0.25 milligram and I gave 0.5 milligram. I distinctly remember the two errors that I committed, and I know both times I broke my own protocol. I was distracted. I will not blame anybody else. I blame myself. And I know that these two errors always remain in my mind, though it did not harm patient. The doctor said, you don't need to fret so much. It's okay. Patient is fine. You report it. Very good. But after that, I became super duper alert. And I used to train my nurses in the ICU that, any amount of checking is always less for our patient safety. So always remember that. It's very, very important. Coming to insulin, now I have seen that insulin has been the root cause of many errors that I have seen in my life, and especially insulin infusions, the insulin subcutaneous, all of them. And I'm very sure that all of you sitting, if I ask you, have you come across at least one error related to insulin? Can you put it in the chat box? Yes or no? Have you ever come across any error related to uh, insulin? Have you come across, I am very sure it will be 100% yes, because the number of errors that I have, seen around insulin has been tremendous. They're big in numbers, and there some of them were real near miss. Someone told about the loss of skin. It is, yes, it is Steven Johnson syndrome, and that can happen not only to penicillin, it can happen to other drugs as well. So most of the time you are saying yes, 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 wrong syringe selection. Yes, very, very important. You have a, insulin mixture with 40 units in 1 ml and 100 units in 1 ml. This can be really crazy, and I have seen this. IV infusions, when you're giving insulin infusions, that also can lead to errors. The latest error that I came across when I was still an administrator was, the nurse went to change the insulin syringe. She changed the insulin syringe. Patient was supposed to get 3 ml of that admixture per hour. By mistake, she put 30. Can you imagine what would have happened to the patient? But the son was sitting there and he was very alert. So he came out and obviously he made a lot of hangama, and I will not blame him. If I am sitting with my mother and if I see this error happening, I know that this could lead to sudden hypoglycemia if no one notice. The patient can be very badly harmed also. Even it can lead to brain damage. Yes, hypoglycemic brain damage. So we know that. So this is very, very important to keep in mind that when you're working with insulin, be extra careful. Now, when we look at this, it is also very important to remember that do not use abbreviations. Be very careful about the do not use abbreviation, and please speak up. If the doctors are using abbreviations which are not supposed to be used, you can always request the doctor that can you please rewrite, because most of the hospitals in India are still on paper based medication orders. They are not, all of them are not having an HIS. So it is very important for the nurses to be very aware of this. Do not use abbreviation, because with insulin, that can become one of the major root causes of mistake. 10 you can misread as 100. So please follow the safe practices and always ask the doctor, please rewrite. And let me give you one very simple answer. When a doctor asks you, why should I rewrite, can't you read? Just answer only one thing. Sir, I really care for our patient and I want to make sure that I'm doing the right thing. So can you please rewrite this order? Just be polite, but be assertive. And I am very sure no doctor is going to say no to that. So that is your A, P, and I. And the next one is the narcotics. Again, one big, list of, medications under that, all the opioid medications. And those who are interested to understand how these medications have led to patient harm including death, there are a lot of videos which are being released by US, Canada, Australia. You will see that they have made it public and the entire report is available on the net. But if you look for such things in India, it is not there, and that's unfortunate that we are not admitting that we have this problem, and we do not talk about this publicly, and we don't come to know about that. And it's very, very important because now we are also having fentanyl patches. Patients are sent home with those patches. Are we educating them before we send them with all these high alert medications? So now this is very, very important, that how they should use this safely and correctly. These are very important. And please remember that all these high alert medications become very dangerous when we are handling very old patients and very young patients. So this is very, very important to be kept in mind. If you are managing very old and very young patients, you need to be not just careful, maybe 2 times, 3 times more careful, because they do not have the bandwidth to manage a little bit of error also, because of their the age factor, either very young or very old. Now, coming to the chemotherapeutic and immunosuppressive agents. Now, all the medications, all these high alert medications, why they are called as high alert or high risk? It's because the therapeutic, range is very small. That means if you have to give, let's say, if you have to give one medicine 1 milligram, it will give the desired effect. But if you give 1.5, it will become toxic because it does not have much width. So let's say that you are taking an antibiotic of 500 milligram. By mistake, you gave 1 gram. Maybe nothing much will happen because the therapeutic range is larger. Nothing will happen. But you do that mistake with the high alert medications, we can actually push the patient even to fatal outcomes. Now, this is very, very important to know. That's why all these medications are called as high risk or high alert medications. So, this particular report has summarized all of them in very small sentences. That's just a brief about the medications. But I'm very sure those who are handling this medication, they should know a little bit more about it, especially how they work, what are the actions, what are the nursing responsibilities, what should we watch out for, and what should we be alert about. So these things are very important. Now, the last one is your heparin and anticoagulants. Now, I'm sure that in our hospitals, many patients will be getting heparin or fragmin and other things. Now, I have seen in my own career, you know, many nurses probably they will not even know the full form of APTT and PT and what is the difference between the two, and they are giving these medications. There are things to be remembered when you are giving these anticoagulants, whether it is the heparin and fragment that you are giving, or you are giving warfarin, what you need to take care, what is the patient education that needs to be given. Then the newer ones are these new oral anticoagulants, also known as direct acting oral anticoagulants. Now all these generic names even very difficult to pronounce. I'm sure that many of you are using in your specialty. Now all the hospitals will not use all kinds of medication, so that is why it is important. So when I was a administrator, so we had this list of high alert medications. The pharmacy will release with signature, which is approved by the pharma therapeutic committee. So what I told my ward in charges was that please highlight all the ones that you have in your ward and make sure that your nurses learn those medications. It is no point. I don't use Vincristin in my ward. Then I should not worry about teaching my nurses what is Vincristin. But definitely they should learn about heparin, insulin, which is very frequently ordered. So the leaders have to prioritize what the nurses need to learn on a priority based on the unit that they are working, the specialty that they are working with. It is nice to have all this information. Sometimes what I see is I see some very smart nurses. They have a lot of knowledge, what is this medicine, what is the action. They will tell you the entire pharmacopoeia, but when it comes to taking care of the patient, they are not able to do what is to be done before giving the medication, because some medication, some action needs to be done. So if I am going to give warfarin, I should know the PT result. I should know what is the INR, what should be the range. Sorry, what should I be informing the doctor? Just give me 1 second, my throat is really bothering me. Take a little bit of honey. Thank you. So, and also in these medications, when they are sent home, the patient education is very important. Sorry. Telling them that, when they should take the medication, why they should not omit the medication, and if they miss the medication, what they should do. And I know this is a major gap in most of the hospitals when it comes to patient education. So, friends, I hope you can go back and tell your nurses to learn a pinch. Let's start from there. Then we can add the other drugs into that. Okay. Coming to other medications, this document they do talk about some of the high risk and high alert medications. So NSAID, the diclofenac story, it comes in here. because it can interact with other medications and it can lead to patient harm, especially in elderly patients. So it's very interesting to know. Paracetamol is one of the most widely used over the counter medicine, and it has been responsible for the highest number of medication errors in children. Now, this is very, very important to remember, as you know, common medicine as paracetamol can become harmful when it is given to, because all the pediatric and neonatal medicines are based on the weight of the patient. Even normal medications are based on the weight of the patient. So it is very important nurses who work in those specialty, they should be aware what is the expected dose to be given, kind of aware that this is the dose that is usually given to the patient. I have not worked in pediatric and neonatal units. I'm an adult critical care nurse, so there also some medications are based on, weight, and there are some ranges. So as you work in a particular specialty, you take time to learn these, parameters. Then lithium based, the treatment that is given for psychiatric disorders, they also have very narrow therapeutic range. So all these medications like for digoxin, potassium, all this, we are sure that we also look at the blood level. We look for serum potassium when you're giving potassium, digoxin, you look for the digoxin level. So there are other medications that you are always looking, because after transplant, when you're giving the, anti-rejections medications, that you look for their serum levels. So this is important to know how the levels are, managed. I would only request all of you that wherever that you're working, know those medications. Nobody can learn everything about all the medications in the world, but whatever specialty that you're working, make an effort, make an effort to know those medications. What am I supposed to be looking out for? What is the dose? What is the, route? How it is supposed to be diluted? How it is supposed to be administered? Keep yourself safe. I always used to tell my nurses that, when you try to keep your patient safe, you are also safe. Now, I already told you the story of, patient being allergic to penicillin. So it's very important to ask for allergic status. So this one can see here, I've already mentioned about the older persons, the pediatric and paracetamol, lithium salts. And so now we come to these strategies. So what are the strategies that this document is talking about? First and foremost, they are talking about standardization, the way the medications are named, packaged, labeled, and prescribing. So there are various levels. The country is also expected to work upon how they are named, packaged, labeled. So all our look alike and sound alike needs to be, the number of LASA should be actually down, so that, we don't make that many mistakes. Then assessing for the safety risk of medicine. So there is a list, when you go into that, whether it is barcoding or you are categorizing them, you can look at the risk of medicines, how they are stored. Then reporting and learning systems and pharmacovigilance centers. In India also there is hemovigilance and pharmacovigilance. Hemovigilance is related to the blood transfusion, and pharmacovigilance centers and pharmacologists, they are supposed to report certain incidents that are happening. So that for nurses that is not critical, but this processes needs to be there. And you need to adopt multiple strategies to prevent errors around the risk or errors with the high alert medications. So several risk reduction strategies can be used together. That's what most hospitals they do. They make an SOP. Now I am just highlighting a point here. High leverage risk reduction strategies such as forcing functions and standardization may be bundled together. Now, forcing functions means, let me give you a very basic example, that when you are giving a high risk medicine, we are saying there should be a double check. We are actually forcing that one more person should check. But sometimes you do a shortcut there. The one more person just simply signs on the medication chart. That is not safe. So somewhere we have to be holding our integrity and we do the right thing the right way. That is also important. And it's interesting to know the low leverage strategies such as staff education and passive information. So we do talk about training and education, and whether it is in quality or any domain. When you talk about this, does not come out as a very high impact intervention. The high impact intervention is how do you make the system or the process safer. So that's why electronic systems and barcodings, etc., are cited to be safer than paper based medication administration process. So now you can always look for processes and strategies which has proven effective elsewhere, and those things are easily available if you care enough to go and look for it, and you find how others are achieving safer medication process, even if it is paper based. So this is some of the strategies are here. So one of the things is, maybe some of you are already aware of FMEA. You can do a self assessment using FMEA, identifying the hidden risk, because this is a proactive tool that is part of the quality improvement tool. Or error proofing design, that means build in safeguards to prevent or respond to failure. Now, for example, in one of the hospitals, in the medication chart itself, they redesigned the medication chart. In the medication chart, when the getting the doctor to prescribe directly into the medication chart, I always champion for that. You can then take away the transcription errors. In olden days, doctors used to write in the doctor's order, then we will transcribe it into the medication chart, and then we will give it to the patient. So there is a possibility of making mistakes. So many hospitals now have gone ahead and they're asking the doctor to write once, but write it directly into the medication chart in capital letters. And they have given space for the dose and the route and special considerations, so the doctors can easily make those notes, and for nurses it becomes a learning tool as well. Maybe you would like to consider that. How is your medication chart designed? This is very very important. So error proofing designing can happen something basic like that, or you can even go up to the level of electronic systems where warnings are popping up. It is stopping you from ordering any medication which is out of range for that patient. So there's a lot of things, lot of systems are working on. Then limiting access and use, and we know that we have got all the highlight medications are restricted for use. Their storage is restricted. Narcotics are kept in double lock. Why are we doing all this? Because they all have very narrow therapeutic range. So their ability to create harm, even if a small error is made, is very high. So that is why we need to be very careful around this medication and maximize access to information. How do we make sure that our nurses, when they are managing this high alert medications, that they are aware of these medications? So let's say that you are working in an ICU, or you are working in emergency or any area. The question is that you give information. How do you check that they are aware of this information and they will be able to recollect this information? Constraints and barriers. Use special equipment for work. I'll give you one example. So when we had that problem of insulin, instead of 330 ml was punched by mistake by the nurse. So what we did, we talked to the biomedical engineering and we identified, I think, 8 or 10 syringe pumps, and we made sure in those syringe pumps, even if anybody wanted, they could not punch more than 8 number. That 8 number was given by our doctors, because we were using those syringe pumps for insulin and heparin. This was the most common two medications. So the doctors told us, all said and done, even if they punch in 8, it is not going to harm the patient, but they cannot put another zero there. So this is called, you are doing a engineering control. That means you are just forcing that they cannot. It's a constraint, it's a barrier that you are putting there so that this will not reach the patient. So there is a possibility you can think of such things, forcing actions or constraining actions, so that people will not land up making the mistake. The other thing is to standardize. Can you get, if you are getting high alert medications in two three different names, are you going to help someone, or you are going to confuse the nurses? There is a possibility, because one medication, when it comes in 10 different names, nurses can, anybody can get confused. Now it is up to the senior management to think about, can we standardize everything? Standardization will also mean how the drugs are prescribed. Even that needs to be standardized. Are all the ICUs prescribing the drugs in the same way? Are all the wards prescribing it the same way? When nurses get pulled in and pulled out, are they getting confused? In my unit, this is how it happens. In this unit, I'm so sorry, I did not know that. So, are we making those kind of things happen, or are we simplifying the processes? Are we simplifying the handover and shift handover? Are we simplifying, or are we making it too complicated? One of the dangers that I have seen in recent times with all kind of processes is that we put too many checklists, and these checklists, they become tick list. That is the least effective. When they become tick list, when you give too many forms to a nurse to kind of tick tick tick, she will only tick, she will not actually do it. So you need to figure out how much an assigned nurse should be actually documenting and ticking. Is somebody else supposed to give that supervision? Is somebody else supposed to do that audit? Think about it. Centralize error prone processes. Can you put control checks so that you can reduce the distraction of staff? When it comes to medication safety, it is proven through various research, and there is enough evidence to say that when nurses are giving medication, they should not be distracted. So I think in 2009, this idea of nurses wearing a vest or a sachet to say that it is medication time, so nobody is calling that nurse to do something else for the patient, so that can be, you will be able to reduce the errors. Then preparation to respond to errors, having enough stock of reversal agents and having antidotes. There is this very famous story about a pilot's wife in US. She went in for a very small, I think it was some kind of a ENT surgery. And while they were trying to, they gave the anesthesia, they were going to intubate, and they found that they were not able to intubate. That particular day, it was a bad day for that family, for that patient. So many people came back to try, whether I can intubate. Anesthetist came, intensivist came, everybody is trying to intubate, but nobody thought I can just simply reverse this, anesthesia. You can give antidote and make the patient, you know wake up. There was lot of time wasted because this is called unintentional blindness. This is something that you have to do, in your head, but somewhere we are just overlooking around that, or you don't have the necessary antidote or the reversal agent available. So these stories I'm just sharing is only to say that there are so much of hidden risk for our patients. Now this is again taken from that technical report that I am referring to. I thought of showing this to you because when we were documenting allergies, description of reaction was not captured, and I thought this is a very good idea to ask the patient what kind of reactions do they get, so we will be able to know whether they get mild reactions or they are getting major reactions. So this is very important. So the allergy is drug slash allergen. That means somebody can say I am allergic to shellfish. If somebody is allergic to shellfish, we know that they cannot be given iodine based contrast. So we know these things. So you can have one drug allergies and other kind of sensitivities captured, so this is available to all. So when we were in Fortis, we even went ahead and we used to put a stamp in every single paper with the patient record to say this patient has allergy, 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 because we had couple of times when the doctor said, "Oh, I was not aware this patient is having allergy," because it was written somewhere else. So we started putting a stamp across all the papers. I don't know what is the uh, practice now. So it is very important at the time of whether it is paper based, when you indent also, if the patient's allergy is captured in the system, it can be flashed. Now coming to the healthcare provider factors. Now healthcare providers factors are multiple, starting from the prescription, storage and dispensing, then administration to the patient. Now, the last part is what I am trying to highlight to all of us, who is very close to the patient, not the prescriber, not even the dispenser, not even the storage. All these things are important. Who is standing next to the patient is the administration. Now, when the patients are hospitalized, this is the nurse who is there, who might be able to protect the patient from coming to any harm. But when they go to community, when they go back to the hospital, it becomes the responsibility of the nurse or the pharmacist or the doctor to explain what they need to take care at home when they are taking the medications. So now next is patient related factors. What are the patient related factors? Very young and very old, which I already told. Polypharmacy, that means patients who are taking multiple medicines at home or even in the hospital, 10, 14 medications could be a challenge. Multi-morbidity, multiple, problems the patients are having apart from just the age factor, or they have high risk medical conditions, they have renal failure, hepatic failure, cardiac problems, they all increase. And the education, what are we educating the patient, this also becomes very important. Are we educating them to take the medication safely? Are we educating the caregivers that what they need to do to be safe with medications? These are the questions one need to ask when you are going about improving the processes. Last session also we talked about the 5 moments of medication safety, and someone told me in the last session that, I'm going to put this poster across in the hospital. I really hope that you have done that. And these 5 moments can be applicable to nurses also. Before starting medication, giving medication to the patient, before giving medication, know your medication. When a medication is added, do you know why this medication is added to the patient? Do you review all the medications? When the medication is to be stopped. So the other day, someone was telling the doctor told to give a medicine for 3 days and then stop. Okay. But unfortunately, on the medication chart, somebody did not write stop. After 3 doses, they did not write stop, and the patient continued to get that medication till the time doctor did not ask. So you can reconcile the medication on doctor's rounds. In our ICU, this was a common practice that every day, very quickly, we will go through all the medications the patient is getting to confirm that the right medications are going to the patient, and then the all the medications which needs to be stopped are stopped. And in my ICU experience, where I was the in charge, all the nurses were regarded as the guardian of patients, because that's what the doctors, they trusted the nurses to warn them. We have not talked about this. We haven't thought about this. So that is the responsibility. That is the accountability that we can give to ourselves when we are looking after the patients, because they may not be able to speak up for them. So the question for healthcare professionals, do we have the right education to manage all these medications? Then there is an entire human factors about the design of the process. Is the team working together? Are we investigating the medication errors, whether it is small or big, it doesn't matter. And how are things working in the real world? So this is very important to remember how things are working in the real world. I am a trainer, so I train lot of nurses throughout the year from 2012. So sometimes I feel, that somewhere we say, oh, I have this in my hospital, I have this in my hospital, we have this process in my hospital. So are we working in the real world, or we are not admitting that there are things that can improve? If there is nothing to improve, if we say that everything is, going perfect, there is nothing going wrong, it is very difficult to believe, right? So it is very important that, to know the reality in your systems, very important. Prescribing, dispensing, administration, monitoring of medication should be subject to audit. Now this is very important. Are we doing enough audits? When students are being prepared, do they know that how these medication safety audits are being done? No, are they aware when they go into the system, when someone is telling them that, yes, you can start to give medication? The fourth point I would like to emphasize, if there are leaders here, this is something I learned many years ago, that I cannot allow a nurse to give medication unless and until I am privileging the person. So they are using the word here, clinical revalidation and relicensing. What does that mean? That you have to prove every time that you are safe to work around with medications. Do we have such process? This is what this document is talking about. Then, of course, the medication reconciliation. Maybe before 2000. 10, this word was not very prevalent. Today's date, the word is very prevalent. That means every step, when the patient is moving from one place to the other, are we doing the medication reconciliation? Or when patient comes to the hospital, moves around, goes home, medication reconciliation. Every OPD visit, are we doing medication reconciliation? My mother is 84 and she takes about, I think, 8 or 10 medications. Every time when we consult a doctor, I am there with her, so I kind of tell you, these are all the medication this my mother is taking, and then I will ask, this dose is fine, the test results. So I am little aware, so I do ask all the questions. Now, the patients who come to us, not necessarily someone is knowing about the medications, or if they know, they may not be knowing everything. Who is those patients, safety champion? I can only think of a nurse, well educated, well aware nurse who is good in critical thinking, who is aware of the medications that is being given to the patient. They can be the most safest champion a patient can have at any time. Now, coming to the work environment. Now, this is system errors. These are very, very critical, and we should remember this. And this is very important for all the leaders to ensure when nurses are very busy and understaffed, the risk is going up. When we don't have adequate supervision, the risk of error is going up. When nurses are interrupted when they are giving medications, as ward in charges, do we just tell the nurse when she's giving medication, hey, your doctor has come for rounds, go for rounds? Which is wrong, because let her or him finish the medication without any interruption. Are the nurses tired, or are they multitasking? Now, this all sounds good, but someone needs to do something about it. I already mentioned about poor chart design. That means the flow chart or the drug chart that you are using is not designed and it is not easy to use. These are questions that you can ask yourself and see that where is it that I can make things better for the nurses so they are safer in their sphere of work. Specialities. Some specialities are already with high risk. So we know that oncology, very high risk. Critical care, very high risk. Emergency, very high risk. Anesthesia department, very high risk. So we know these, departments, have special attention to them, have special process check audits to see that the medication process is safer. The environment where the IV admixtures are prepared or reconstituted, are they safe? The people who are doing it, are they privileged to do so? Is there a formulary available for all the clinicians, including the doctors and nurses, to refer if they have questions about the medications. Are they aware of drug interaction? Can the system throw up that there is a drug interaction for this patient? Drug food interaction, all this can be built into the HIS of any hospital. Now, these are all, hidden factors in the work environment which can be mitigated with proper design if you are aware. Now, you might be thinking all these are not a nursing responsibility. Maybe some of them have to be facilitated by the leadership, but can we voice and say that these are the hidden dangers and we would like something to be done? Now, this is another screening tool, Stop and Start, which is started there in the Western world, especially for patients who are older to see that they are doing the right dose and the right questions are being asked. Now this is from the NHS. This is actually a poster which is available to all the clinicians out there. So what they should be, they're asking stop and ask all these questions, then look for these things, and then you can learn from these sites about the medication. So people are working round the clock to make sure the medication process is becoming safer. So everyone has a role to play in medication safety. Everyone has a role. I'm not saying somebody else is not having the role, but my only request to all the nurses is please be proud about the role that you have in ensuring safety of your patients. Know the medications before you give to the patients. Check the patient, check the medication, that you have all the five rights ticked off. Ask the patient and explain to the patient. Make the patient a party to your process. This is very, very important. Now, very quickly, a very small, very, very short video I'm going to share with you.
Well, now to another story uncovered by CBC News. This one revealing a major medical mistake. More than 1,000 cancer patients may have received watered down chemotherapy drugs. Our health reporter Kelly Crow has the story.
I'm calling from the Cancer Center. I'm one of the
Hundreds of cancer patients are just now receiving the disturbing news that they were injected with an underdose of their chemotherapy drug.
The underdosage may be as little as 3% or as high as 20%.
The mistake happened at 4 cancer centers in Ontario, in Windsor, London, Oshawa, and Peterborough, and at one center in St. John, New Brunswick, affecting a total of about 1,000 patients.
The hospitals are offering them a rapid appointment with their oncologist to discuss the situation.
For an entire year, the 5 hospitals bought the drug from a single Ontario supplier, not realizing they were underdosing their patients, until a pharmacy technician at one hospital noticed something strange.
The bag that they were using, the solution that had been provided by the supplier, seemed to be a little bit larger than the other ones. And so through some inquiry and due diligence on their part, they felt that there was an issue, and then they notified us because they knew that we were also using it. And from there, we all commenced to try to investigate what was actually happening.
This is the exact sort of mini bag we're talking about. It was 250 mils.
The drug was mistakenly diluted because there was too much saline in the IV bag. But why was the bag too full?
That's the critical question here, I guess, and that's why we're investigating this more completely.
The 2 drugs, cyclophosphamide and gemcitabine, are part of a chemotherapy regime for breast and lung cancers, as well as lymphoma and leukemia.
It's a serious mistake has happened, and we're dealing with patients who were under treatment for cancer, so it is serious.
Oncologists say the impact will be different for every patient, but the main risk is that the treatment will be less effective.
But if you look at all the factors that are involved, the likelihood of this causing a significant diminishing effect of their chemotherapy regimen would be quite unlikely.
The premixed chemotherapy was produced by an Ontario company called Marchese Hospital Solutions, and late today the company issued a statement saying it's confident it met the...
So friends, this last video I just showed just to emphasize the fact that, just being alert. When something out of the ordinary comes your way, stop and ask the question. So this happened in Canada, and this is identified by a pharmacist. Just asking the question, the admixture, because it's already prepared chemo that is coming, why the bag is looking bigger. That's how the inquiry started, and the country has, made it public, and they are discussing about this so that others can, look at their own processes. That is what is called learning from errors. Now, how many times we are able to share mistakes that is happening in our own hospital, in another unit, and making sure that we are doing something to ensure that our processes are safer. So that's the end of today's discussion, my dear friends, and we are going to have the next session on 19th, and that time we are going to discuss medication safety in transitions of care, ensuring safety during transition and medication reconciliation. So that's what we are going to discuss next week. And thank you for being here with me. Stay safe and stay positive, and I'm going to stop the recording. Thank you for being here. And after I stop the recording, I will open the floor for any discussions or any comments that you may have. Thank you so much. All of you are still here with me, and see you all next Friday.